All right. We are going to talk about vesicular, bullous, and sloughing rashes. It's morning right now. This is a great way to start my morning. All right. So let's hit vesicular rashes first. All right. So vesicular rashes, what we're going to hit are herpes simplex 1 and 2. We're going to take a look at varicella or chickenpox, herpes zoster, which is, as we all know, and we'll talk about, sort of a late life transition of varicella, hand, foot, and mouth disease, contact dermatitis, because they also have vesicles, and then a little bit about something called dermatitis herpetiformis that people may not know too much about, but I just want to mention it in case it comes up because it is a rash that is increasing in prevalence. So we'll talk about that. How about that? All right.
So exciting.
Yeah. How about we start with herpes simplex virus? Mel, you and I did a segment on UC Max about herpes simplex. So I think this is just a thing we have. We like to talk about herpes. Well, it was a good segment, by the way. All right. So we're going to do the 10,000-foot view of it, though, here instead of like the super deep dive. But basically, there are types 1 and types 2 of herpes simplex virus that affect people. And they typically cause these mucocutaneous infections. So historically, we've thought of HSV1 as the one that causes cold sores, right? We thought HSV1 caused herpes labialis, and we thought of HSV2 as the one that caused genital herpes. The truth is now it's getting to be there's much more crossover now. And so you can't reliably say that one is HSV1 and one is HSV2. If you wanted to know that, you would have to do a PCR or a culture. So either way, they cause these painful, blistering rashes. The first episode of either labial or genital herpes simplex can be accompanied by fever or systemic illness. And the thing about these things is that they tend to recur. Actually, Mel, I remember the joke that you told from our segment, which was, what's the difference between love and herpes?
Herpes lasts forever.
So, lesson learned. All right. So there are other sites of infection that we should know about where herpes simplex can infect us. It can give us a meningitis, encephalitis. People have probably heard about herpes encephalitis. That could be a big deal. And they may not have the rash accompanying it. So you're going to have to do all the appropriate testing, cultures, et cetera, to find out. Skin, you can have, wrestlers get herpes gladiatorum. Like there are other places you can get it, herpetic whitlow. I'll show you a picture of that in a second.
Gladiatorum?
Yeah. Yeah, that's what. I'm pretty sure I'm right about that. Now I have to look that up. But yeah, no, herpes gladiatorum was the one the wrestlers get, skin on skin. You can have visceral organs when if you're immunosuppressed. HSV keratitis is something that you should be able to recognize. And those dendrites are the hallmark, the dendrites that you see on a fluorescein examination. This can cause blindness if it's not recognized early. And so, it could be this, it could be herpes zoster keratitis when you see those dendrites. Either way, you're going to get ophthalmology involved as soon as possible. All right. Any questions on that, Mel?
No, I don't think there's any questions, but herpes simplex 1 and 2 can occur anywhere. The primary event can be quite severe, antivirals if you get them early, and then in the eyeball, bad. It's potentially eye-threatening. Got to make the diagnosis, dendrites, lots of eye drops, ophthalmology. Got it.
Herpes labialis, here's a picture. As I said, often HSV1. Many people acquire this in childhood. The vast majority of people across the world have antibodies to it. Not everybody gets cold sores, just the lucky ones, I guess. Tons of asymptomatic carriers help spread this, exacerbated by stress, illness, sun. There's an association between erythema multiforme and herpes simplex that just, if those come up on the boards, just remember that they go together somehow.
And we should say that the first episode of herpes in kids, herpes stomatitis, can be really bad. They can't eat, they can't drink, sometimes have to be admitted. And then that'll go away, and they might have recurrent herpes or they may not. They may be asymptomatic spreaders, they may not.
That is the whole problem with herpes. Is there are a lot of people walking around who are these asymptomatic and just spreading the love and the herpes. Yeah. And so, yeah, exactly. A first time episode, you may have a significant systemic illness. And these poor kiddos, when you see them with their herpes, gingiva stomatitis, first of all, there's lots of questions to answer to the parents about like, no, it's not really herpes. But then, you're going to have to take care of them. All right. Genital herpes. Here's a Corpy classic case. Okay, this comes straight out of Corpendium from the textbook. 23-year-old previously healthy man presents with vesicular lesions on the penis. Symptoms began 3 days ago with fever, malaise, lymphadenopathy, followed by the development of the rash. And the patient reports recent sexual activity without the use of barrier contraception. So this is what you're going to see. You may see pictures that accompany it. This one is a perianal genital herpes breakout. This is a pretty substantial ulcer. And so remember, when the vesicles pop, they can leave ulcerations and the whole thing is quite painful. This is herpetic whitlow. So when I was saying there's different names for herpes on the skin, I put it in red, Mel, so I think it's okay to ask you, what is the main thing to remember about herpetic whitlow?
Keita's laughing because I said, don't ask me any questions. I don't know any term. But herpetic whitlow, you do not want to stab it. And it looks like it's a felon. It looks like it needs to be IND'd. But if they've got those vesicles on there, they've got the story in there, it'll just spread it. It just makes it work. It's a classic foil on the test. They'll show you a picture and say, want to IND this? And the answer is, and no, I don't.
So a general rule of thumb of mine is not to touch things with gloves. That's a good rule. Okay, here's something that you should recognize. This is called eczema herpeticum. Terrible eczema can get super infected by really almost any germ. Bacteria, you'll see obviously staph and strep infections too, but eczema herpeticum is something to really know about because this can require hospitalization. These kids can get really systemically ill. So recognize it when it's eczema, a child who has a history of eczema, it looks infected and you see painful blisters. If you see vesicles, then you've really got to think about it and they're going to need to be treated with antivirals. All right. Let's move on to varicella.
Okay.
So have you seen, you're old enough to have seen chickenpox.
Back soon.
I'll be coming back soon, right? So vaccination rates wane. We are seeing chickenpox more, and so it's important to be able to recognize it. The vaccine overall really did reduce the incidence. Same sort of thing with all these viral stuff. You've got this prodrome, fever, malaise, and then you get this classic rash, which comes out not all at once. It usually spreads centripetally. And so the lesions are in separate stages whenever you see this person, which is an important distinction from smallpox. I doubt they'll ask you about smallpox, but smallpox can look like this, but everything comes out all at once, just FYI. So this classic dewdrop on a rose petal thing this is chickenpox. So you've got this red little area, tiny little discrete lesion, and then the dewdrop is the vesicle, which will then pop and then crust over. And so again, lesions in different stages, very itchy. That's a hallmark. These are more itchy than painful usually. They can get super infected. So if you have a few that are getting, because they scratch them so much, if they're getting really red with spreading redness from it and actual pus drainage from the vesicles or anything like that, then you may be dealing with a super infection. They'll turn into those sterile pustules. Usually they'll look a little opaque inside and then they scab over. Then those scabs last a couple of weeks. And when they're all scabbed over, that is when that person is no longer contagious with chickenpox. Okay.
Okay. So central out, itchy,
Itchy.
dewdrop on a petal,
Yep.
rose petal, and hangs around for a few weeks, can get super infected. Yeah, smallpox was the big thing that this was differentiated from, but there hasn't been a case of smallpox since 1979, I believe. Which is just one of those amazing public health things you need to read about.
Okay, so varicella, people do get breakthrough cases, but they're usually very mild, just a few vesicles. So if you see something like that with a few dewdrops and rose petals, it's probably a breakthrough case. I don't think they're going to ask you about a breakthrough case on the boards, but you should probably know about it. Just also, you should know, though, that the immunocompromised and neonates are more susceptible to severe illness, like with just about everything. But they may get the pneumonia, encephalitis, some kind of super infection. They can get hepatitis. Rye's syndrome was first really, as my understanding was first really discovered as an association between children's aspirins and chickenpox. But they can develop Rye's. And so unprotected patients meaning they don't have antibodies at high risk of complications who present within 10 days of exposure should be given the varicella zoster immunoglobulin. Okay, so if they are at risk or they're not properly immunized and they're coming within 10 days of exposure, they ought to get the immunoglobulin. So who are high-risk patients for varicella? Pregnant women without evidence of immunity. So you could actually test their titer and see if they're immune. And if they're not, then they're going to need the immunoglobulin if they're exposed. Immunocompromised patients who don't have any evidence of immunity. Newborns. So it's between 5 days and 5 days prior to or 48 hours post-delivery. Any premature babies. And by the way, all these people can get primary chickenpox from shingles, from herpes zoster. Yes. So that's important. If they've been around a person with shingles and they're not protected from chickenpox, they can get primary chickenpox. So they are going to need the immunoglobulin. Okay? Okay.
That's a really, really important point. Shingles is infectious.
Yes.
Shingles is infectious. And if that person is around a high-risk person, that person should get immunoglobulin if they're not priorly infected. Good point.
Ta-da. Okay. So here's a picture of it. This is drastic shingles. I think this is great. So you see, okay, so shingles again, grown up varicella coming back again. It sort of lives dormant in the nerve roots and then decides to come out. Oftentimes in periods of stress or when you have an important event coming up that you don't want to have shingles for. And so classically what you'll see is this dermatomal distribution. That's kind of how you know, usually, is that you'll see it. It takes up a dermatome. Now, it can be systemic in immunocompromised people, people with low immune systems, people who are on chemotherapy, they can get systemic shingles. And so we call it systemic if they've got 3 or more dermatomes involved. If it starts crossing the midline, it's not really supposed to cross very far over the midline. You can also get complications of pneumonia, encephalitis. And so again, the mainstay of treatment here, antivirals. You're going to start them early in the course, early if possible, to try and prevent post-herpetic neuralgia. There's some debate whether you should bother after the first 3 days, but I tend to treat, if they're uncomfortable, I tend to try to treat them with the antivirals. And pain management, they might need legit analgesia.
Go over that rash again because it's classically dermatomal, so it follows your dermatomes. It does not usually go across the midline. If it crosses the midline, think of something else. It can go a little bit, but your dermatomes really stop in the midline. And that's usually just one dermatome or 2 dermatomes. And as we've heard here, if it's 3 or more, then this is sort of a big outbreak and maybe they're immunosuppressed or they're going to be pretty sick. And it hurts. The other thing we should say is that it's often pain first before the rash. And so somebody will come in when you think they're having a splenic infarct or a renal infarct or something because they have this deep, boring pain, and then the rash comes. I don't know if they'll test it on the exam, but clinically in the real world, that happens all the time. It's like, I don't know what's going on. Have a really good look and see if there's a little tiny rash under there, some vesicles. That's where the pain's coming from.
All right. So bad things about herpes zoster also, that they can also wind up in the eye, right? And there is a classic sign that they may ask you about on the boards that has a name to it. They may be the harbinger of herpes zoster ophthalmicus, which is Hutchinson's sign. Hutchinson's sign. Yeah.
So the tip of the nose has the same innervation as your cornea. So if you see vesicles on the tip of the nose, it suggests it's in the cornea. Am I getting this right?
You got it right. You've got it right. So if you see that, so it may spread then to create a keratitis. So if you see that and you're diagnosing shingles, just know that the eye is at great risk. If it's not already, you should examine the eye under fluorescein. But if you don't notice anything yet, you should be getting that person to see an ophthalmologist quickly. Ramsay-Hunt is another one of these named syndromes associated with zoster. And this is where they get shingles in the ear. And so it's affecting the geniculate ganglion. It can cause ear pain, a Bell palsy. Vesicles in the ear canal is the tell, so you're going to have to look. And it can also be associated with hearing loss, tinnitus, or dizziness. And so you should always look in the ear when somebody has unilateral facial weakness, because then you could be the hero that diagnoses Ramsay-Hunt.
They love the complications on the exams. So if it's on the nose, into the eyeball, Hutchinson's sign, drops, lots of antivirals, call ophthalmology. If it's in the ear ball, then it is the Ramsay-Hunt syndrome. And same thing. They're going to treat them aggressively and you get them followed up. So it's the complications of these zosters, the one that goes into the eyeball, the one that goes into the ear ball. The eyeball one is the worst one.
All right. So our goals are to treat early to prevent postherpetic neuralgia, which is a big problem. The shingles gets better, but the pain doesn't go away, and the pain is bad. So we'd like to reduce that if we can, and so early treatment might be able to help with that. We want to prevent superinfection if we can, so we're telling people like not to muck with it too much, right? And if there's pain, we treat the pain. So antivirals, analgesics if needed, consultations if you've got eye or ear involvement, or disseminated cases are going to need to come into the hospital for intravenous antivirals and lots of consultations. So if there's CNS involvement, which does happen, or they're severely immunocompromised, disseminated, these are phone calls you're going to be making to the people who are taking care of them, that kind of thing. Those are much higher levels of management. So just recognize they can be quite sick. Let us move on to hand, foot, and mouth, which can cause vesicles, right? So here is a classic case out of Core P. 2-year-old male presents with refusal to eat and fussiness. He is found to be, which sounds like a lot of 2-year-olds actually, but they'll eat white things only. No, this one won't even eat popsicles or white items. So presents with refusal to eat and fussiness. He's found to be febrile to 38.3 with a punctate, painful vesicular rash in his mouth and a non-tender rash on his hands and feet, all with an erythematous base. All right, so this is, you're getting the most classic case in which you actually get the rash and the mouth, and there are hands and feet and mouths involved and a fever, and so you know. And hopefully that's what they would give you on the boards, even though we know in real life, like you probably have like one of the spots involved. So go ahead.
McCullough makes this comment that it should be called hand, foot, mouth, and butt disease.
Yeah. It does hit the butt a lot of the time, right? So maybe they try to fool you by showing a picture of the butt, and you're thinking like, I don't know, hand, foot, mouth, butt disease. So just know that is a thing. So the rash can be, you can't count on the rash looking like a certain kind of rash. So the mouth is usually vesicular, and that's going to be a tell. Or if they pop, you'll see tiny little ulcers. But the rash itself on the hands and feet and butt can be macular or papular. It can be vesicular. It could be a combo special. Who knows? But so you're really looking for like a sick looking kid with these varieties of rashes and things in the mouth. And a lot of times if it's just the thing in the mouth and you know that it's going around, you're probably going to make that diagnosis anyway. But for the boards, I think they would help you out with an additional photo or something like that. And then you would know that there's no specific treatment. It's really supportive care of this kid. All right. Contact dermatitis can also be vesicular, often is vesicular, right? So this is a classic, this is highly vesicular to me. Usually they're not quite as vesicular. They're like little vesiculars, but this feels like a little bit like smallpox. And so, so this is sort of a classic thing. There's 2 types of contact dermatitis. There's irritant contact dermatitis, and there's allergic. So irritant is because the thing itself is causing cytotoxic effects on the skin. This is not an immune-mediated thing. This is just like a cellular insult from the actual thing. So detergents, solvents, things like that. And that can create this sort of vesicular linear. This picture, I think, is more classic. If they're going to show you a contact dermatitis, they're probably going to show you these linear vesicle kind of things. The allergic ones, just know it's immune mediated, this delayed hypersensitivity. So you're not going to get it the day of, it may be like the next day. So poison ivy, poison oak, those types of rashes, you're going to have a little lag. And I bet the picture they're going to show you is going to look a lot like this. The management, the main thing that they want you to know is that, well, for irritant dermatitis, you're gonna treat it pretty much the same way with some steroids and avoiding the thing. And if it's still on the skin, you want to get that off of there. Allergic is probably where they're going to focus their efforts. You're going to use topical soothing methods, antihistamines for the itch, topical steroids if it's not super widespread. If it's widespread, this is the thing. Yes, you're going to put them on oral steroids, but you need to keep them on there for like a long time. Like they need to be on them for like 2 to 3 weeks at least, because otherwise they will rebound. So that I feel like is the board's worthy thing to know.
Remember the classic sort of metal bracelets, necklaces, earrings, classic things where you can get this contact dermatitis.
Yeah, then you just develop a dermatitis. So yeah, cheap jewelry, stuff and nickel is usually the offending agent in that case. And so yeah, those are all going to be some cheap jewelry with nickel, right? You need the real bling. That's what you need. All right. Okay. So those are our vesicular rashes. Let's hit some bullous rashes. Okay. So, I mean, bullae are like, they're basically big vesicles, right? It's derived from the Latin bubble, just because they're sort of bubbles, right? But basically yeah. They're basically big blisters, right? They're usually over a half a centimeter, and they can be flaccid or tense. So flaccid, like you like blah, 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 just, if you poke at it, as opposed to tense, like that bubble's not going anywhere. It's like, if you look at bubble wrap and the bubbles are nice and fresh, then they're like tight bubbles versus like the half like deflated, no fun bubble wrap. Okay. So they're hard to pop. All right. So we're going to hit bullous pemphigoid, pemphigus vulgaris, and we'll talk about keeping those two things straight in your mind because that's hard. I get them confused a lot. And bullous impetigo is another thing that's going to come out with bulla. So bullous pemphigoid, this is chronic, autoimmune, usually older. So pemphigus vulgaris is usually younger, and they're sicker, right? This is sort of a chronic thing. It can be serious, like it can be a real, it can be a life-altering disease. But usually older adults, very large, tense blisters or bullae. It can be in one spot. It can be wide. Do you remember Nikolsky's sign?
But that's where the skin just sort of sloughs up. You can like push the bigger and bigger.
Yeah. So it doesn't do that. And so, a lot of times you'll see it in these like intertriginous areas, flexor surfaces. And so first it's like a rash, and then there's more blisters and vesicles, and then you've got these big bullae. And so this is going to be a referral to the dermatologist. They'll do all the biopsies and that kind of thing. But this person is not usually going to look ill. They'll do they might put them on NSAIDs and steroids. If they look systemically ill, like you're going to admit them because you're going to be like, this person's really ill with a blistering rash. I don't know what, this person's sick. They need to come into the hospital. And they may get, if it's really widespread, it's almost like burns. They're going to get these fluid and electrolyte imbalances. And so they can actually need ICU care when it's that bad, but that's rarer. Usually it's this sort of indolent chronic thing in an older person, as opposed to pemphigus vulgaris. So I remember vulgar is bad, right? So of the two of them, vulgar is bad. So pemphigus vulgaris is, I don't want either one of these, but like pemphigus vulgaris, it might even be too old to get. Usually this is younger people, or it can affect younger people. Like you can see it in older people, but if they're going to give you a classic case, it's going to be a younger person. So these are flaccid, thin blisters with a Nikolsky sign. You push that thing over and then the skin's just going to slough off, right? And so skin, mucosal surfaces, often a large body surface affected. And there's, again, a wide differential for any of these things, but they're going to look sick. So they're probably, if they're really sick, they're going to come into the hospital. Otherwise, they need dermatology soon, because they're probably going to be on steroids and they need the biopsy, they need the follow-up. And so, again, if they're sick, if they're dehydrated, which they can be, if they're getting metabolic disturbances from the fact that their skin is all coming off and you tend to dissipate a lot of important fluids that way, they're going to need to come in and get care. But younger people, positive Nikolsky, vulgar, because it's bad. It's worse. So here's a picture, like the skin starts coming off, right? Yeah. So autoimmune, blistering again, mucosal surfaces, potentially fatal. Right? This is like potentially fatal. So peak ages, they say 40 to 60. Like I even as young as 30, I think I've only seen it a couple of times. It can be drug induced. They're going to have to do a lot of any of these blistering diseases. There's going to be a lot of workup when they're really sick to figure out like, what is this? And we'll talk about some other things that slough, because this is sort of bullous into sloughing. We're going to talk about sloughing in a second. But this is something that's going to need, it's like an all hands on deck situation. This is when dermatology needs to come in. Basically, they're not coming into the ER, but they're going to come into the hospital and they're going to see this person. Okay. Bullous impetigo. These people are not quite as sick. They have impetigo, but they have a staph that is giving off the same exfoliative toxins that cause scalded skin syndrome. So the same thing that kind of makes things, sort of the skin start to separate from the dermis. So the lesions are usually going to be on the trunk or extremities. Localized vesicular eruption, then this fluid-filled bullae, and they can rupture pretty easily. And then these clusters of shallow erythematous lesions, they leave like a scaly, that's classic scaly thing of impetigo. If you recognize impetigo from on the face, a lot of times you always see a picture of it between the nose and the lip, the honey crusting, that kind of thing. So there's going to be some honey crusting, but with bullae, right? That's going to make you think of bullous impetigo, which is a subset of impetigo, typically on the trunk. And if it's is superimposed on atopic dermatitis, it can actually be a little more widespread. I don't think they're going to do that to you. I think that they would show you this picture of like a honey crusted thing with a bulla somewhere on the torso of someone probably relatively young. Although this does happen in older people than impetigo we think of as like little kids. You can see this in slightly older ages. But you're going to have to just go on the fact that they're not very sick. Okay. All right. And so now we're looking at bullous impetigo. You'll notice the bullae, there's some crusting with it. Person's not that sick. Talk about the sloughing rashes. None of these are good. I'll just say that at the outset. Like if they be prepared to do all the things. So we're going to talk about staph scalded skin syndrome, which I alluded to a moment ago, toxic epidermal necrolysis, TEN, and these guys are on a spectrum, TEN and SJS, Stevens-Johnson syndrome, SJS, and so they all love the initial. Staph scalded skin syndrome. You would recognize this, like, okay, something is wrong here, right? And the skin does seem to be peeling off. So quadruple S, staph scalded skin syndrome, starts with a local infection with staph, and then the toxins from the staph cause the skin cells to slough. And this is usually going to be newborns and young children. We don't tend to see this in adults. You can see that same toxin causing something like a bullous impetigo, but you don't see it, the widespread whole body thing that you will see in the newborns and the little kids. And so this has a positive Mikulski sign with, sloughing of the skin with just slight rubbing. So the things that have positive Mikulski signs tend to be like more, the skin comes off much more easily. And so those are like pemphigus vulgaris, like it comes off, right? Which will leave you with a situation where you're going to have to manage this, if they get lots of electrolyte disturbances and things like that. So first they have the scalded skin. Now in this skin tone, you may not see it as scalded skin. In a child with lighter skin, you might see that it looks erythematous first, and that's where the name comes from. And then you're going to see these they're very fragile bullae, then the desquamation. And so it can be just one part of the body, but I mean, when I've seen it, it's been more generalized. One very important note, and for all of the sloughing diseases, anything that actually creates vesicles and things like that, always look in the mouth. Always look at the mouth and the mucous membranes. You want to know, right? You want to know, is this affecting the mouth? Because that sort of changes your differentials. Staph scalded skin syndrome will not affect the mouth. It doesn't affect mucous membranes, unlike TEN. So they may be sick with it. They may have fever, chills, skin tenderness, malaise, irritability. So they'll have a systemic illness along with it. And also that differentiates it from impetigo when they're usually not that sick.
Now, this was a bit of a pearl for me. I don't remember knowing that staph scalded skin syndrome does not affect the mucosa. I looked it up in a number of references. Most of them agree that it does not. Some of them say in severe cases, it can even involve the mucosa. But in most of the cases, it looks like that staph scalded skin syndrome, SSSS, is differentiated from these other bullous conditions by the fact that it does not involve the mucosa.
So fluids, antibiotics. Clindamycin is an important pearl here too, is because clinda, even if you're going to give them other antibiotics, clindamycin stops the exotoxin formation. So it will stop the sloughing. It will, or at least further sloughing. So if you can get rid of that exotoxin, then that's going to help the whole process. So you may be double, triple covering for all sorts of stuff, but you want clinda as like the first thing that you're going to reach for. And then local skin care, wound care, you're going to admit them to the hospital. Again, burn center type thing. Okay, so TEN and SJS, same disease continuum. They can cause severe mucocutaneous, so yes, mucous membranes and cutaneous reactions, and then necrosis, and then the epidermis detaches, which just sounds so awful. some things to know is that medications can be a trigger for this. And so common ones are things like allopurinol, NSAIDs, aspirin, sulfa, also associated with HIV and lymphomas and vaccines. And I don't think they're going to ask you that. I think they're going to make this a drug-associated reaction. So the SJS is the less severe end of the spectrum. What's an easy way to remember this? I don't know. 10 is like, so, oh, here. Yeah, it's got a scale of 1 to 10. 10 is the worst. But 10, you have to remember that 10 is the worst. It's like the most severe manifestation is 10. So SGS is the less severe end of the spectrum. Usually less than 10% of the body surface area is affected. And 10 is going to be more than 10. Actually, it's really more than 30 because there's this overlap area. Why did they do this? There's an overlap, SJS/TEN overlap area between 10 and 30%. But so the more severe, on a scale of 1 to 10 to 10, right, that's going to be the toxic epidermal necrolysis. And then less is going to be the SJS. Now, this to me seems completely academic because you're going to be watching the person with SJS to see if it evolves into TEN. And I get that you're going to be more aggressive with the person who has TEN, but you're still going to be nervous when you're looking at SJS, right? So, this is look in the mouth here is, I think, the point to note in this person. You can see that there's some swelling and edema, and this person has mucocutaneous involvement. You can also see some of the skin rash starting on the chest. This one is bad, right? This is toxic epidermal necrolysis. I mean, like, look at the skin, like this person. And you can tell by all the other things in the picture that this person is sick, right? Yes. So they're not well. And so they will also get a prodrome, right? A flu-like thing, maybe a burning sensation in the eyes and the mouth. That means that this thing is coming. That's the harbinger of the mucosal involvement. You do get mucosal or conjunctival involvement in probably 90%. So that's going to be your tell. Like, look in the eyes, look in the mouth, mucositis, stomatitis, genital involvement. So you got to look at all those places. And so then you're going to know if you start seeing that. The conjunctivitis might be your first clue, but it should make you pretty nervous. And really just look at the drug list. All right. So yeah, so they can have all sorts of eye symptoms. So they could just have photophobia, right? But if they've got eye complaints, then pay attention to that. Purulent conjunctivitis, they can have bullae of their conjunctiva. Oh, that sounds terrible. Corneal ulcerations. If they survive and they're very ill and their eyes were really affected, they can have long-term vision problems. So they're going to also need ophthalmology to come in and take a look at things. All right. And so last little bit here. Just remember, remove the offending medication. If they've got more than 30% of their body surface involved, this is a true emergency. They're going to need ICU, burn center care, lots of supportive care, fluid pain management. And that is it for my sloughing rashes and horrible diseases that nobody wants to be affected by, Lecter.
Thank you. Just a reminder of all the terrible things that can happen. The worst part of the Bible right there.
Oh, yeah, right. This is definitely an affliction. But important to recognize. And so I think that really for the board's purposes, like being able to identify the rash, putting it within a class of diseases and saying sick or not sick, and then knowing generally like antivirals or supportive care or ICU or burn center or call dermatology, needs a biopsy, like those, those are the things. I don't think they're going to ask like real nitty gritty stuff about it. It's going to be like, what is this and how do you manage it?